Hey, well, thank you very much. It's so nice to be able to share some time with everyone halfway around the world. Now, these are my financial disclosures. I consult for Alcon, J&J, and RX Sight, which makes the light adjustable lens. So as we're all doing more of these advanced technology lenses, these are all of the steps we have to go through. We have to evaluate the patient, select the best IOL, educate and counsel the patient. We have to get the right sphere and cylinder. Then we do the surgery, and then, as you just heard, we may need to surgically enhance. So the surgery, which is what we focus on all the time, is just one of these steps. And these are the steps that actually, though, are most critical to determining the success in the sense of the patient being very happy. So this has gotten more difficult because we have so many choices. And it's a little bit like my granddaughter here. When you have too many choices, it creates a lot of questions and confusion. And just think about what we now have to eat off and multifocals. In the United States, we have sort of a pseudo-accommodating. We can mix these different ones. We have enhanced monofocals. We have to talk about monovision or blended vision. And then we have to explain toric. And then we have specialty lenses. We have the light adjustable lens, and you heard about just now, the IC8. So this is the problem. There's a lot to understand, and yet optics are confusing for patients. And we use all of these tricky terms, and then concepts such as depth of focus and focal distance, which are very hard for many people. This creates a lot of anxiety in the patient. They have to choose the lens. They frequently have to choose which distance we're focusing on. And of course, we do this over and over again. It gets very frustrating how much time we spend in the office and then with follow-up phone calls and questions. So I'm going to talk about some practical things that I have learned that have helped me. I did more than 1,000 of these lenses in 2024. We have to start with a patient questionnaire. This is the typical Dell questionnaire. And this saves us a lot of time because the patient records all of these things. But you have to start with some basics. And we talk about everybody is going to get one of 3 kinds of lens implants. We don't say there's 8 different kinds. All right, so you're either going to get a single focus lens, an extended focus lens, or a multiple focus lens. Try to simplify it. Now, I don't say monofocal because this gets confusing with monovision. And then we explain that if you have astigmatism, we can build that correction into any one of these platforms. All right, so that simplifies it. Now, these are the questions patient asks. So I won't need any glasses, or I won't need reading glasses. Will I see 20/20? I want to read, but I don't mind distance glasses. We get these questions over and over again, and the problem is these are not yes or no answers. And that's because patients want to simplify the world. They want to think in binary terms, yes or no. And so we have to explain that there's a continuum. And in school, we all could get an A or a B or a C or a D, and this is what that means. So this helps me. If a patient has a nuclear lens and they say, but I seem to be okay, I see okay, I explain, well, you can get by. It's a C+, but it could be an A if you had cataract surgery. And when I explain that they have an epiretinal membrane, the patient might think they're going blind. So I said, well, I know that even with glasses, you won't have perfect A, but maybe it'll be a B+. So then they understand there might be some slight limitation. We can use this to help them understand any of these other concepts, irregular topography or a prior retinal detachment. And then when they say, you mean I still need reading glasses? If I have a multifocal, why would I pay extra? And then I give the concept, here in the United States, I say, well, if you move from a cold city like Chicago to a warm city like Miami, it'll be much better if you hate the cold, but you might still need a sweater sometimes in Miami or a jacket. All right, so this is another problem. Patients think they could choose. I either want far or I want near. And this is what happens when the patient says, yeah, I don't mind distance glasses. And they don't understand the concept of the continuum, because this is what we think of when we choose these different lenses. And that's the defocus curve. And that's how we figure out what they want. So what's helped is it's obvious to us, but not to patients, and to explain that the eye is like a camera, and it has to shift from far to near. And this is the key thing. I told them there's four. We can divide that range into 4 zones. There's far. Zone 2 is indoors. So I'd say it's like someone at the other end of the dinner table. It's the walls in this room. Of course, arm's length is zone 3, and reading distance is zone 4. And I talk about the 4 zones. And when I describe this is all so basic. I shot a video with my cell phone explaining the 4 zones. And this is something we show them in the exam room, and it's on my website for them to view prior to surgery. Now, what we're really doing is explaining the defocus curve and these sort of refractive targets that you see here. So the first thing you have to do is tell the patient what they have. You have one eye at zone 1 or one eye at zone 3. Or, how do you describe if they're -6? I say, you're not at zone 4, you're at zone 7. You're really close. You have to look at what kind of glasses they have and explain. Okay, you have single vision glasses for distance or just for reading, zone 4. Oh, your bifocals cover 1, 2, and 4, but you don't have zone 3. And then a progressive, you have all 4 zones, depending on where you look. And you explained presbyopia. You went from an autofocus camera. Now you have a manual focus camera. You need 3 different pairs of glasses to manually change the focus to each distance. And then you ask, how often are they wearing the glasses? Because some people have their progressives or trifocals and say, I don't really wear them around the house. And you're just determining how valuable would it be for that patient if they had more depth of focus and range. All right, so with a single focus distance lens, let's say you have a myope and they just want a monofocal. Well, often we're going to aim for -1. And how do you explain that? Well, now I can say we can choose either zone 1 or zone 2. If they want to read without glasses, I can explain how zone 3, -175, might be better than just zone 4. And monovision, I explained, if we made your eyes this different, zone 1 and zone 4, they're not going to work together. They work by themselves, whereas blended vision is just a little difference where your brain will fuse much more easily. A multifocus, it covers 4 zones. It gives you function at 4, whereas the EDOF, it helps you with 3 out of the 4 zones. You'll need reading glasses. What's the benefit of these options that I've circled? It's not that you never need glasses, it's that you don't need trifocals or progressives or switching between 3 pairs of glasses. And that is where there's a huge value, and if patients understand that, they're very interested in these options. So let's take just one example, okay? A popular lens in our practice is the Vivity. We explain, but you clearly can't say you won't need glasses. So it has more zones than a monofocal. It's the most zones we can get without introducing side effects at night. It reduces how often you have to switch between glasses, and you won't need trifocals. That's how I explain the value of the Vivity. Now, would you like this lens, or for your patients? Both eyes would be binocular distance. You'd be able to drive at night. You'd have the convenience to, look at a lot of things in zone 4 without glasses. And then when you really want to sit down and read, you put on reading glasses. That sounds pretty great. We don't really currently have that lens. So how do we get that? We blend the Vivity and the Panoptics. Explain the benefit of the Vivity is you have excellent vision at night. In California, everyone has to drive. Everyone drives at night. But the weakness is you still will have to put reading glasses on to see your cell phone, often a text message. Now, some people can do it without, but you can't create that expectation. The strong point of the Panoptics is you will be able to see a whole bunch of things like putting on makeup, price tag, cell phone, but you're going to have some rings at night. And this is what patients have often heard from their friends. Oh, they're having terrible problems with these halos at night, and they're very, very worried about this if they've been talking to people. So now we are creating this sort of this decision. I have to choose between two choices that both have undesirable outcomes. And that's why people have trouble, many patients have trouble deciding. So if I tell them in the beginning that a popular option that they're most likely going to be happy with is to have one of each, basically they don't have to choose between, these advantages and disadvantages. They're going to be able to drive safely at night, and they're not going to need to put on readers just to see their cell phone. And so this is very reassuring to people. And of course, they're going to do one at a time. So we say you can have the best of both worlds. Now, we're doing one eye at a time, so they actually get to test drive one of these lenses. If they say the cell phone is really important and we do the Panoptics first, we do it in the non-dominant eye. If they say night driving is the main reason I'm having cataract surgery, I'm going to put the Vivity in the dominant eye as the first step. And you're just leaving them the option to have the other choice in their other eye. So this is a good way for people that are used to good distance vision, because we're not compromising by making one eye closer. And this also helps us to compensate for residual refractive error when both eyes are being targeted for emmetropia. All right, now what do you do when the patient says, well, will I see 20/20 or 6/6, doctor? Because patients seem to know that. And we then, again, have to explain that your eyesight isn't binary, okay? It could be, well, you want distance. I say, well, it's like when I putt, a cataract surgeon, I only get one putt. Whereas with contact lenses, we can keep taking more and more putts. So your distance vision might be an A, might be excellent, but it also might be a B+, and then if you need to, you could wear glasses. And then I say with LASIK, that putt is more difficult. It's more unpredictable, like an uneven green. So, it's possible it could be a C, but you can always wear glasses with all of these options to get an A. And then we explain that the light adjustable lens, which we use a lot in LASIK patients, gives us multiple putts. And that's something that over time, it will eventually become available around the world. Well, if you do a multifocal, so I'll never need reading glasses, right? Well, not exactly. We have to explain again. It won't be excellent without glasses, it'll be good. But if it's good and you have good lighting, then this is what you can see with either zone 3 intermediate or zone 4 up close, and you explain the concept of good lighting. But anytime you want to see like the tiniest detail, like you're sewing, you put on readers and you'll have an A at that point. Now with a single focus lens, if we target distance, your zone 4 will be very poor, and you may feel like you want to have glasses on so you don't have to all the time, so you don't have to hunt for your readers. And EDOF, it gets by, but it's not, you're going to want to need more help. So that's how we explain it. Then they're going to say, well, with the distance, so that means I never need any glasses, right? I can drive without glasses. Well, again, it's not exact. So sometimes it helps to say, by using these advanced technology lenses, you're going to be able to do a lot of things without glasses, but then there'll be a list of things that glasses really help you with, sewing, freeway driving. So, what we're trying to do is maximize the things on the left, and if you have astigmatism, then a toric multifocal is going to put the most activities on that list to the left, whereas the single focus without the most on the right. It's very important for patients to understand the concept of compromise. And, we tend to think of this as quality versus convenience. So the multifocal, obviously the rings, but you need readers to look at the text message. So again, you tell them, and you have to choose what's more important to you But if it's too bothersome in one eye, we'll put the Vivity in your other eye. That's maybe 10% of patients. But most choose the multifocal for the second eye. So that's kind of how I explain it if people really, really are a great multifocal candidate. And the light adjustable lens, this is what we in the United States have when a patient's very uncompromising. Either their eye is uncompromising, like they've had myopic LASIK with a lot of ablation, or the patient themselves is very compromising. I don't ever want to wear glasses for distance. I've never worn them my whole life. All right, now that's the method of which I have found it's helped so much to help patients understand the value and the limits and realistic expectations. How do we actually go about doing this? In my practice, it's really unrealistic. I try to do one consultation because patients are referred, and then sign them up for surgery and choose the lens. So for that to work, they have to, before surgery, go and learn about the concept that there are these advanced technology lenses that they will pay extra out of pocket for. We mail them information, we direct them to my website when they're in the waiting room or waiting during dilation. We have an idea, we've looked at their questionnaire, we have them kind of read about a specific lens. So you have to explain the basics of cataract surgery with the brochure, explain that there's this option that they're going to have to choose the lens, and before they come in, if they can understand, we're going to choose from 3 categories of lenses, and that we need to figure out how we're going to cover 4 different zones of the camera. That helps. And then of course the Dell questionnaire is their chance to think about what their priorities are at home and to record it so that I can have a record of that, but also I can quickly see what they have decided. So this is the way I set up my website. Before your consultation, this is what you need to read. Okay, so they see that video describing the 4 zones, I describe it, and then on the questionnaire, I also describe it. Now, the questionnaire will establish that there are these lenses that you pay a premium for. Here's the 3 categories of the lenses, and the camera has 4 zones to help you understand it. This is your wish list. I prefer no glasses for distance, mid-range, or near. This is the priority. If you had to wear glasses, which are you willing to do? You have to choose. And then I added this analog scale, which is very important. And that is to say, put an X on this scale that describes you. Prefer glasses all the time, or I hate glasses. And this is really one of the first things I look at. It tells me, how much interest there is or how much benefit there might be for one of these AT-IOLs. And then I have patients go to this choosing your lens where I list the lenses that I am doing, and I have a little handout that I've written for these. So I don't want to hide the fact that there are many lenses. We live in an age now where you get information at your fingertips, you're talking to other patients. So I describe what lenses we're going to talk about, and I just leave them here, but I'm going to help the patient narrow it down. And then, of course, when we do the consult, they come in. So we do the pre-testing and the refraction before I see them. That includes the biometry. Before we do tonometry, it includes a topo, a wavefront, and a macular OCT. And then my optometrist does the refraction. We dilate them. They're waiting. We maybe give them a handout or show them a video that we know is going to be pertinent to what we discuss. I do the consultation, trying to have a family member in the room and recording the conversation using their cell phone voice app, and then we schedule them for surgery. So that's our workflow. So we know we do the wavefront. That's important. If you have a cornea like this and you're trying to make sure that, is the cornea going to reduce the best corrected acuity? Obviously, we have to rule out a subtle epiretinal membrane or other pathology. And the biometry helps because, the Vivity isn't available in all powers. Or, I can see that a toric is going to be recommended by the Barrett formula here, so we're going to need to discuss correction of the astigmatism. So, I do have a handout for each lens. They're similar, a lot of copy and paste. But what this is my informed consent. And this is where in my 4-page handout I describe the need that some people need for refractive enhancement, or that there might be circumstances where the lens that we agreed to might not be best once we're in the operating room, such as with a capsular tear. And then, where possible, I might make a video, which nowadays is so easy. You're just filming yourself talking about some issue. It could be the importance of dry eye. It could be, the 4 zones of the video, and you can put that there. We should not, I don't think, be lazy and just using things provided by the company, which have a very positive bias. And so that's why I just wrote these handouts. And again, we basically put this on the website, we print it out and give it to them, but we try to narrow it down for them to decide. This, again, if you go to my website, let's say you wanted to learn about the light adjustable lens. There's a lot to explain. So I have handouts about post-op. I have a video where I'm describing the light adjustable lens so that I don't have to repeatedly get burned out by saying the same thing over and over. So practice pearls. It sure helps to have a family member there because we're discussing costs. There's a lot to remember. And the family member is going to want to know. So often they don't have their family member there. So every cell phone now has a voice recording app. My staff helps them set it up, and we record the discussion. This helps them understand it better, to play it at home. They can remember it better. Other family members can understand what was going on. And this has dramatically reduced the need to have follow-up discussions. And if there was a misunderstanding, we reduce that. Or in rare cases where the patient said, "You told me I never would need glasses," we can go back and listen to that. And then I have them, with their cell phone now, take pictures of some of the issues that helps them remember it. So if we diagnose this ERM, have them take a picture of it. So they remember, how come my left eye doesn't see as well as the right? Remember we showed you that you have this little membrane on the retina. The patient might often say, well, no one ever told me I had astigmatism. So we say, well, this is what an ideal cornea looks like. And you have these yellow areas that focus differently than the green areas. That's called astigmatism. We have them take a picture of that. And if their topography is really irregular, for any number of reasons, map dot fingerprint dystrophy, Saltzman's, we can explain that this is part of the camera that also isn't ideal, and that may affect your vision. The final topic is who discusses the cost. And I personally found that it helps if I do this, because if you look at a range of options for us to reduce astigmatism, how are we going to narrow this down? For the patient that says none of this is in my budget, I can quickly reassure them that they're going to see beautifully, and the glasses may not be that strong, but they will need glasses. If they're very cost sensitive, I might direct them toward number 1. But I have to know what's their budget. And then other patients say, I have no constraints, it's my eyes, I want the best match. And that way, if the light adjustable lens is the best match, I may do that. So anyway, this is our goal, is to have all of our patients end up 20 happy at the end. And so thank you very much for sharing some of these practical pearls.
Thank you so much, David. I think it was an excellent talk on patient counseling, and you put it down all so simply. And we all know yet it is so difficult. It is not easy, but all the complexities you have simplified. So thank you so much. If there are any questions from the panel.
Thank you, sir. That very nicely you explained the concept of 4 zones and 3 type of IOLs, which make the things very easy for the patient's expectation, whether they want spectacle independence or the quality of vision. If your patient is a ophthalmologist, a surgeon who has to do surgery after getting his surgery done, So what will be your options to that person? What type of IOL will you offer? What choices will you offer to that ophthalmologist, sir?
In short, how many, I mean, what is the type of IOL you have implanted in ophthalmologist size?
Yeah.
It's very interesting because as I think most ophthalmologists are not choosing a multifocal. That's just the way we are. Some ophthalmologists will come in and say, you know, particularly the older ones, I'm sorry to generalize, and say, I just want the basic lens and monofocal and I'll wear glasses. I don't mind glasses. But I think more and more ophthalmologists in my practice are choosing, and optometrists are choosing the Vivity in terms of maintaining good contrast. But I would say a lot are choosing the light adjustable lens because with good, basically excellent quality and figuring out just how much myopia in the second eye works well, but to increase the range. And so that's what I'm doing a lot of there. I do think that having both eyes in the distance is helpful because when we use the operating microscope, the slit lamp, the indirect, having one eye blurry is not ideal. So that was part of your question. Again, I'm very impressed with how many people with, again, the Vivity in one eye or the multifocal in the other, like a Panoptics, that seems to work really, really well. And it's not mini monovision, you're still binocular. And that's always a great question is what would each of us have? And, if it were me, I would have mini monovision with the light adjustable lens. I'll just throw that in there.
Thank you, David. Yes, another question.
Yeah, namaste, Dr. David. So, Dr. Arvind Maurya from this part of the planet. So, you have elaborately discussed the monofocal, EDOF, and then the multifocals, and then the LAL. So, in between, because we need an IOL with minimum dysphotopsia and no halos and glare, right? And also no to minimum positive dysphotopsia for the night drivers. So, in between, there is this LensTech ClearView 3. So it doesn't have any refractive or diffractive rings and no posterior apodization. And the optic size is little bit larger. So there is no aphakic area on the temporal as well as the nasal side. So that's why there is no dysphotopsia and no halos and glare. So what is your take before going for LAL type of intraocular lenses? Also, they have excellent depth of focus. So when the post LVC corrected patient, so the biometry readings, sometimes they go haywire, right? So we need an IOL that has an excellent depth of focus that gives a flexibility. So this LensTech ClearTech, what is your view regarding this IOL?
We just only recently have that available in the United States. Unfortunately, we don't have a toric version of that. So that's really hampered things. It's just not yet FDA approved. That's another excellent option depending on the patient and so forth. And again, I think a mix and match would be excellent there. My understanding is it doesn't do the intermediate quite as well. So I would tell the patient this is really good for the cell phone, but for zone 3, it doesn't have such the continuous range. I think the beauty, it just took me a while to realize that when you talk about 4 zones, it gives a language to differentiate between all 8 kinds of lenses. And so you can use that language to explain what you want to explain about, in your case, the clear view. And it just finally, I can't tell you how often patients see that video and they say, that's a really good video, or I really understand it so much better now. It's so obvious to us, but we have to realize it's not obvious to patients. Thank you for the question.
Thank you, Dr. David. I just wanted to make it clear on behalf of so many of us, I hope there is no copyright on your understanding of the 4 zones and the 3 types of lenses. Can we right away start it from Monday?
Yeah, no, absolutely. My website is public domain. It's Chang Cataract. no space. So you can see how I educate patients. And I mean, I just looked at my numbers for 2024. I did more than 1,000 of these lenses. There's just so much discussion and so forth, and I couldn't do it without a really good way to explain things concisely and efficiently.
In their language. Thank you.
So one question I had was, in 1,000 lenses that you have implanted, then there would have been some dissatisfied patients also with EDOFs, with multifocals, not because of the lenses, but because of the fact that they have different occupations or whatever. So how many of these would you have explanted, or have you explanted or exchanged any of these lenses? And if you could tell us about that.
So I would say that in that 2024 year, I would have probably explanted 5, out of those 1,000. So you're never going to be able to avoid that. You must be willing to go back. And usually, I tell people if they have a symphony or a multifocal, test your vision at night, and then we'll decide what to do in the other eye. And there are still people that say, I love it, I don't really, and they get a multifocal in their second eye, and then they come back and say, I can't stand the halos. So not only do you have to tell them to test their vision at night, but you have to tell them cover your other eye and only look through the multifocal eyes. Again, so obvious to us, but not to them. So exchanging the lens is so easy. I think that we should be very willing to do that. Almost everybody who has a bilateral multifocal, if you just put in a lens such as the Vivity or monofocal in the dominant eye, they will be fine with the rings and the non-dominant, because at that point they understand, and you've just created this hybrid. So the hybrid is hugely, hugely, hugely important to patient satisfaction, the hybrid approach.
Thank you, David. I think thanks for your time. I know it's very early morning in California. Thank you for being with us and for sparing your time today. Thank you, and looking forward to seeing you again in AIOS APO Delhi. Dr. David Chang is also the presidential guest of Dr. Partha Biswas for the conference, and you will see almost all of us there. Thank you.